As Dr. Poulos said, I think there's a great introduction by the speakers before. A lot of the things that I'll present actually sort of will follow up on this. And also many of the talks afterward sort of will emphasize some of the points that I'll also make as well. But what I want to get everybody on the same page is that when we deal with Lennox-Gastaut as a pediatric neurologist and a pediatric epileptologist I'm head of the epilepsy program at Seattle Children's Hospital. I've been here in Seattle for almost 10 years. I moved from the Northeast, from New England, at Yale, where I started the pediatric epilepsy program there. But this part of the country is very unique in that we take care of not only patients here throughout in Seattle, but actually throughout the whole Pacific Northwest. We actually cover the 5-state area, including Alaska, Montana, Idaho, and the state of Washington as well. So it's a challenge, and we see a very large population, and many of these patients have Lennox-Gastaut. And as we know, epilepsy is very common, and we see it most commonly in pediatrics. It affects 1% to 2% of the population. And Lennox-Gastaut is observed in nearly 50,000 patients, both adults and children. Over 10.5 million people under age 15 years of age have epilepsy, and 400,000 in children live in the United States. And roughly about 13,000 patients have Lennox-Gastaut syndrome. And over 3.5 million people develop epilepsy annually, and almost 40% of them are under the age of 15. And as opposed to this country where we see a bulk of patients with epilepsy, it's actually more commonly in developing countries, and the causes are very different. I think when we come to Lennox-Gastaut, there's different approaches to I think the important one with what I want to emphasize is talk about treatment and how do we treat seizures in individuals with Lennox-Gastaut. And I think the most important thing when we treat any condition as a physician or a neurologist is sort of the basics of getting an important history of the seizure. It's really listening to the patient, listening to the family, what are the behaviors and the events that we are concerned as being seizures, and getting a description, what we often refer to as an aura, or detailed description of the event, how often does it occur, and what type of seizure it is. And nowadays, with modern day smartphones, people often take videos, so I see videos of events of concern to help make a decision, are certain events a seizure or not. But it's really listening to people, their patients, and the families that's really critical in helping determine, is it a specific type of seizure, is it a specific event. And then we use other techniques. We often do an important physical and neurologic examination. And as you've seen by Dr. Porter and others, the EEG is really paramount in terms of making a diagnosis and being able to differentiate, is a behavior a seizure, what type of seizure it is, and help you make a decision as to what kind of treatment are you going to use. And nowadays with the technology, and I'll talk a little bit more, is that a routine EEG is takes about a half hour to do. It only gives us a diagnosis in roughly about 30% of the time does an individual have epilepsy. So a routine EEG has limited, but we have new technologies where we can monitor EEG for longer periods of time and be more specific about the diagnosis. And neuroimaging is also an important tool that we use as a neurologist to help, again, identify underlying etiology. And it's become clear, particularly with Lennox-Gastaut syndrome, trying to make the diagnosis early and early intervention is really critical, both to choose, hopefully identify the underlying cause, but more importantly, choose the right medication at the right time. Because what happens with Lennox-Gastaut and many forms of epilepsy in children is that the condition evolves over time, the type of seizures change over time, and you need to constantly reevaluate, is the treatment that you're giving having a positive impact? Is it making an impact over time? And so there are, being able to both do these things very regularly, reevaluating how treatment is going is very critical. As I mentioned, basic to the question of a diagnosis of of seizures is the EEG. And the EEG itself, as Dr. Porter was pointing out, can determine sometimes make a specific diagnosis if you actually record the EEG, but also certain patterns can tell you is there a risk for seizures or a risk for epilepsy, and even depending on where the changes are, what type of seizures and what type of epilepsy. And nearly 2/3 of individuals with epilepsy have abnormalities on their EEG at some point in time. And all patients with LGS, by definition, have very specific abnormalities. But oftentimes, if you study individuals particularly with the LGS, the types of patterns change with age. And more importantly, it makes an important determination of what you're going to consider as far as treatment. And we can also do EEG over longer periods of time just to help you differentiate, is this specific behavior a seizure or not? If so, what type, and what would we choose to use as far as medications? As I mentioned, nowadays there's many different ways with our technology as to how to do EEGs. The typical routine study is 30 to 45 minutes. They often do what's often referred to as provocative maneuvers, such as flashing lights or photic stimulation, as you may have experienced. We often try to do a period of hyperventilation because that elicits certain types of seizures. And in certain situations, as Dr. Porter mentioned, recording sleep is very critical to help differentiate certain types of seizures. And we often use sleep deprivation or other ways to sort of induce that. But nowadays, the technology is available that we can actually do EEG in the ambulatory setting for 24 to 48 hours, where patients go home with an EEG recording system and can help you address, is a specific event a question? But more importantly, it gets a longer picture of what's happening and also during sleep. And so I think there's an important issue in relationship to many types of seizures, relationship to sleep, as one of the questions was brought up. As I'm going to sleep, I have this movement. Is that a seizure? What is that? And so that technology is available both to do at home with and without video with current systems. Or in some cases, we bring patients into the hospital and can record EEG for hours to days at a time while making changes in medications, either discontinuing medications or introducing new medications as well. So there's a lot of ability to be more specific and make the right diagnosis, identify the right type of seizure, and help and certainly make the diagnosis of Lennox-Gastaut. And when it comes to, at this point in time, and as was discussed before, we typically choose medications based on the seizure type. And knowing the specific seizure type is very important as to making decisions regarding choices of medications. And currently, I think it's important to recognize that current medical treatment are treating the symptoms. They're not treating the underlying causes. But many clinical trials that have been used to identify is a medication effective or not have been based on the type of seizure. And so that's how we know what medications to choose based on clinical trials that have been done, whether one medicine is going to work for this type of seizure or that type of seizure. And so we know in children with Lennox-Gastaut syndrome, the most common cause of, or common seizure that almost all children have is what's called an atypical absence, which is maybe a brief or maybe a prolonged period of confusion or inattention. And those are very difficult to differentiate from other behaviors, and that's why it's often critical with the EEG to help you differentiate that. But then there are seizures that are clearly obvious, like the generalized tonic seizure, which is a motor seizure, or the atonic drop attack, or the generalized tonic-clonic, or convulsion as well, are certainly obvious clinically, but there's often very specific patterns that we see on the EEG to help you differentiate the various types. And then myoclonic seizures are another common type that's seen in Lennox-Gastaut. But what's most important is the type of seizure often changes with age. Oftentimes the medication we give changes the type of seizure and may help with one type of seizure, but then brings out another type of seizure. So being able to recognize that those kind of things happen as you're treating is really important, and being able to use the EEG as a tool to help you answer some questions and address whether a treatment is working or not is very important. Another condition that happens very specific to Lennox-Gastaut syndrome is something called non-convulsive status epilepticus, which is basically one of these periods of atypical absence seizure that goes on for minutes to hours at times, where they can be in this very confusional state for several minutes to a couple hours, and we don't really know what's the impact of having that kind of seizure on the brain development, but we actually know there's a form of epilepsy we see in children called childhood absence epilepsy, which is very common, and that we know that during those periods of time, even as short as 3 seconds, that's going to lose your attention, lose your ability to obtain any learning, even from a 3-second period of these generalized discharges. And so clearly, these periods of time, that what we refer to as atypical absence, impact cognition, impact the ability to learn, and it's important to recognize and differentiate those atypical absence that are truly seizures versus ones that may be happening for several minutes to several hours that what we would call evolve into non-convulsive or atypical absence status. So when we think about treatment, overall as an epileptologist, the goal is to eliminate all seizures with either no or minimal side effects. And that's a challenge. But a child, what we ultimately want is a child or an individual with epilepsy to lead a full productive life, and hopefully controlling the seizures, minimizing the side effects is going to lead to that. I think we've seen this slide before, and we're fortunate these day and age to have over 40 different types of medications to choose. We choose medications based on their seizure type, but also based on what clinical trials have been done for specific types of seizures, but more importantly, also based on the mechanisms of action. How do these medications work to control seizures? Do they have very specific targets? And also based on that information, what clinical information has been from trials as to the type of seizures that they control. And so that's where these certain combinations that Dr. Poulos brought up, that it may not seem in some combinations, because the medications work by different mechanisms and different types, such as the valproic acid and lamotrigine, one works by inactivation of sodium channels, the other works by increasing inhibition. So those combinations may work better. And we know studies like Dr. Poulos is doing and other people are trying to identify what combinations may work for different types of seizures, and also what drugs are targeted toward those particular type of seizures. As Dr. Poulos mentioned, and we also know that many of the new drugs that have been, now if you see this chart, they're now what we refer to as third generation drugs that have been available for the last 10 years or so. They work by different mechanisms of action than they have in the past, but also what they've really improved upon is decrease in side effects, and also the availability of more formulations than we had before as well. In choosing a medication, there's several considerations. Topmost, we want to be specific as to what is the seizure type. What is it fit under a specific epilepsy syndrome? And as we know, there are very specific clinical trials done with LGS. What's its efficacy? What's its mode of delivery or the formulation? Is it liquid? Is it a capsule? Can it be given IV? What's its cost? Cost is becoming a big, particularly with many of the new medications. What are the adverse side effects? And are there other medical conditions that they may interrupt? Are patients on other drugs? And those are all important questions that we need to answer before making a decision as choosing a particular medication. I think in the treatment of Lennox-Gastaut, but in general, in all patients with epilepsy, you're always balancing the treatment and the side effects. But overall, the focus is not only controlling the seizures, but the primary focus should be the quality of life of the individual in terms of controlling the seizures and leading to a good quality of life. And oftentimes in Lennox-Gastaut syndrome, in some forms of epilepsy, we deal with optimum seizure control is complete seizure freedom, but oftentimes in Lennox-Gastaut syndrome, that's really not a practical, and that may not be the approach. And more importantly, children and individuals with Lennox-Gastaut syndrome, it evolves over time. So what seizures they may have when they're 3 to 5 years old are going to be very different when they're 5 to 10 or when they're adolescents. And recognizing that, recognizing what medications may be valuable at different ages and different points in time, and also what side effects are you going to worry about at certain ages and certain points in time are really critical. And that's very well known with Lennox-Gastaut syndrome. The aim of the treatment is often not seizure freedom, but it's more to reduce disabling seizures where there's high risk of injury, certainly risk of SUDEP, or sudden unexplained death in epilepsy, and also to minimize side effects. So these are the medications that have been available and are currently used, and the ones with that are with asterisks are ones that have actually been done as clinical trials in patients with Lennox-Gastaut syndrome. Actually, valproic acid has been around for almost 50 years and is a drug that has been a mainstay for use of Lennox-Gastaut syndrome, mainly because it's a drug that has a mechanism of action that controls a broad range of type of seizures. So optimally, if you had a patient with more than one seizure type, if you could use one medication that can control all those seizure types, that would be optimum. But in rare cases, some individuals with Lennox-Gastaut, valproic acid or Depakote can be the one medication that can control 90% of their seizures. But unfortunately, it's a drug that also has side effects. But the other drugs that have come out in the 90s are felbamate, lamotrigine, topiramate, rufinamide, clobazam, and more recently, in the last year, cannabidiol. And there are other drugs that have not had specific clinical trials. Levetiracetam, zonisamide, and perampanel are other drugs that are often used in Lennox-Gastaut. So here's some data from a review on what the clinical trials have shown us, and that you can see these are the frequency of seizures. This is the total number of seizure frequency with lamotrigine, topiramate, felbamate, and rufinamide, and you see, and clobazam is here, and that what's the percent decrease compared to placebo. And so most of the what are called clinical trials are randomized controlled or placebo controlled, versus this is actually specific in a type of seizure that we know is high risk in individuals with Lennox-Gastaut or drop attacks or atonic seizures. And so some of these drugs are actually very specifically effective for drop attacks as well. So, and particularly clobazam and rufinamide have been targeted that type of seizure. So this is a review from about 5 years ago. But also there's a recent study that what's the real use of these in the real world? You start giving these patients with Lennox-Gastaut in large populations, how do individuals improve over time? And this is looking at adding on rufinamide over several months. And you see the dark bars here is what's the areas of significant improvement, and the areas where there's no change in response to the medication compared to a placebo on this side here. But also, if you notice, the white areas at the top of these bars are where they either got worse or they had other bad side effects as a result of medication. And that's something we all know, that adding another medication may help with seizures, but may start see a new problem. And then this is data that's just recently been published specifically on Lennox-Gastaut with cannabidiol. And you can see that there's at least a 40% decrease in seizures with cannabidiol use. And more specifically, drop seizures, or the frequency of drop attacks, actually markedly decrease by at least 40% compared to placebo with the use of cannabidiol. And again, both the total seizure control has a significant improvement with the use of cannabidiol, as well as a significant decrease in drop attacks or drop seizures as well. So again, this is new data. that have been used with a new drug that has been derived from a plant-derived cannabis species. So, as I said, this is a list of the medications that are currently recommended for use with for Lennox-Gastaut. But more importantly, this shows you in this bar or in this column what percentage is there a decrease in seizures with the various medications, but also more important, what are the side effects in what areas, or either the cognitive side effects or behavioral. And you can see most of the medications, you get about 1/3 to 40% have a significant decrease in frequency of seizures or better control. Very small number of patients get complete control with any of these medications. But also, more importantly, is what are the side effects of some of these medications, and choosing them wisely to minimize that. And depending on an individual person, you may want to avoid some of the side effects that are shown here. I think what's also important is that when we think about medications, there are many medications and certain combinations that work well. But when medications that don't work, you need to think about other options as far as treatment. And we know in patients with epilepsy overall, roughly about 1/3 of them don't control with medication. So what are other options? And so some of them are dietary therapies, and sort of the ketogenic diet, or we use both that and the modified Atkins diet, is a very effective for certain type of seizures, particularly the more minor, not atypical absence seizures. It's very effective for. Epilepsy surgery in some cases, and neurostimulation devices such as the vagus nerve stimulator, or more recently there's something called RNS, which is another device that we often use in patients. So this is a recent publication from about 2 years ago, sort of an expert treatment algorithm or expert consensus of how to approach patients with LGS, what are the medications to use. And as you see, it kind of suggests what are the medications that have been shown by clinical trials to be effective, and you should use them in monotherapy in a sequential method, but also based on the type of seizure as to what medication you would choose. But also in parallel with that, you should also consider these alternative treatments to medications, such as the diet or ketogenic diet, or the neurostimulation as well. So this is based on data where there is clinical trials, which medications to use, and try to use them sequentially, and in what circumstances are certain combinations may work better than others, and particularly based on the seizure type. And that seizure type should be determined by clinical description and also by the EEG or the neurodiagnostic study. But I think, as it was brought out at this point, I think treatment is still in that stage. It's empiric. We use it based on information that we get from EEG, and based on what clinical studies have been done in terms of what medication works for different seizure types. And again, medications just treat the symptom, aren't necessarily treating the underlying cause. But as we've heard, there are many more identifying underlying causes for Lennox-Gastaut and many epilepsy syndromes. And this is just a short list of some of those where specific genetic causes of epilepsy that cause Lennox-Gastaut. And more importantly, some of these are now leading to very specific targeted treatments. So SCN1A, which is also a gene that controls the sodium channel, causes the condition Dravet syndrome, a broader phenotype. And there are very specific treatment guidelines as to what drugs are going to be most effective for that genetic cause. SCN2A, there's a condition called GLUT1 deficiency, where there's a low glucose transporter. The ketogenic diet is actually the most effective treatment for that form of epilepsy. And there's a condition where there's a mutation in a GABA receptor. Also, there's a condition known as Angelman syndrome, which is a very specific form of epilepsy. There are specific treatment trials and recommendations for that condition. And tuberous sclerosis is a condition that we see as a cause of Lennox-Gastaut, and we actually know specific genes, but also now knowing the underlying genes are in a specific pathway, there are drugs that target that pathway called the mTOR pathway that are very effective for that type of Lennox-Gastaut caused by that condition. And there's another gene, there's multiple of these genes that now specific drugs are important targets. KCNT1 is a potassium channel gene, where quinidine is a very effective drug for controlling those seizures in some individuals. So I think in conclusion, I think accurate and really early diagnosis of Lennox-Gastaut is really central to its effective treatment, choosing the right treatments at the right point in time, changing treatments when appropriate, constantly reevaluating as the individual ages and the stage of the disease changes. I think medication treatment alone is unlikely to lead to complete seizure freedom, so we always need to think about alternatives to treatment, and you often use them in combination with medication treatments. But the primary focus of treatment is optimization of cognition, the behavior, and overall quality of life, and also reducing risk and severe seizures. I think precision therapy based on underlying genetic causes is just beginning to occur, and this is really showing us some promise, but it's really going to be a subset of patients with this condition, with Lennox-Gastaut, where hopefully we're going to develop new therapies. But you also saw from Tracy's talk how many genes now, over 100 genes are being identified to have epilepsy. Now drugs are being developed that are targeting those, and some of those will be specific focus for Lennox-Gastaut as well. And I think this is where the new promise for treatment of Lennox-Gastaut is going to be, both using old drugs targeting to those systems, but also development of new drugs. Thank you for your time. Any questions? Yeah, well, questions after.